I'm Lior Braunstein, a radiation oncologist from Memorial Sloan Kettering Cancer Center.
And my name is Melissa Mitchell, also a radiation oncologist at MD Anderson Cancer Center.
NRG-BR008, also known as the HERO trial, is a phase 3 randomized controlled study looking to optimize radiotherapy among low-risk, early-stage, HER2-positive breast cancers treated via lumpectomy. So historically, HER2-positive breast cancers had among the most adverse outcomes as far as breast cancer biology is concerned. And as a result, they were treated rather aggressively with multimodal therapy, that being surgery, polychemotherapy, and aggressive radiotherapy. More recently, studies into systemic therapy have demonstrated that this group now has significantly more favorable outcomes in the HER2-directed therapy era, with studies showing outcomes as good as 1% to 2% local regional recurrence at about 10 years, which is about as good as we see in the entire oncology community. And so this was the impetus for the HERO trial, looking to see if we could further optimize radiotherapy among this group of exceedingly favorable outcome patients.
And for this trial, we're including patients who are over 40 with HER2-positive breast cancer, which can be defined either as 3+ on IHC or by FISH criteria. And those patients need to either undergo surgery first and have tumors that are 2 centimeters or less in size, so T1 and 0, they have to be node negative, or they can have neoadjuvant chemotherapy and then go on to surgery. And if they have a pathologic complete response, including no evidence of DCIS, those patients are also eligible for the trial and will be randomized to lumpectomy alone versus lumpectomy and radiation. So one of the questions I get asked the most frequently is, why do I want to omit radiation therapy instead of just de-escalating the treatment by doing partial breast irradiation over 5 fractions? And I would say to that it still has significant financial toxicity, and additionally, patients that live far away, like our young patients in rural communities, it's hard for them to be away, even for a week, away from their families. And globally, worldwide, we know there's a lot of scarcity in radiation resources. So really defining a population that doesn't need radiation at all, I think, is a better choice to make.
We also get asked occasionally about endocrine therapy on this trial, and so because patients are eligible if they're HER2 positive, whether or not they're estrogen receptor positive or negative, endocrine therapy is at the discretion of the treating physician, so that standard of care is typically to provide it for those patients who are estrogen receptor positive. There are a number of correlative studies for this trial as well, and so we'll be collecting biospecimens and also patient-reported outcomes. And so to the extent that the trial demonstrates which patients might feasibly forego radiotherapy, we'll be able to dissect the populations a little bit more to identify subgroups that may or may not similarly benefit from radiotherapy.
I would just ask that physicians that are interested in this trial coordinate with their whole multidisciplinary team, so medical oncology, surgery, and radiation oncology all really need to be on board for this study. We have a lot of people that are excited about the trial, but sometimes it doesn't get presented until they get to the post-surgery setting. So if we can have patients learn about this from their surgeon and medical oncologist up front, that radiation might be an option for remission in the future, I think that would help to increase our accrual to the trial.